Good morning, everyone. Thank you for joining us today. I would like to extend my gratitude to the AAMC for sponsoring this event and making it possible to broadcast around the world for those who couldn't be here today. It is my pleasure to welcome you to UC Davis for the 12th Annual Pre-Medical, Pre-Health Professions National Conference. My name is Miriam Katrina Gadala, and I am a UC Davis alumnus, as well as this year's Director of Pre-Therapy. As Director of Pre-Therapy, I am thrilled to announce that therapy is being represented in our conference for the first time ever. It is my honor and privilege to introduce to you the very first physical therapy keynote speaker, Dr. Paul Rockar, President of the American Physical Therapy Association. Dr. Paul Rockar began his term as president in 2013, where he served as vice president prior to being elected. He is CEO and partner of University of Pittsburgh Medical Center for Rehab Services, as well as the assistant professor at 3 renowned universities. He received his bachelor's in physical therapy from University of Pennsylvania, his master's cum laude in orthopedic and sports physical therapy from University of Pittsburgh, and his doctorate in physical therapy from Temple University. In addition to his outstanding academic performance and active role in the field of physical therapy, Rockar is a member of numerous professional organizations and recipient of many awards, including the Carlin Michaels Achievement Award of the Pennsylvania Physical Therapy Association. Ladies and gentlemen, please join me and give a warm welcome to Dr. Paul Rockar.
Good morning. I want to thank UC Davis for the invite. I'm honored to be here today and to be able to share a few thoughts with you and possibly inspire you a little bit and tell you a little bit more about physical therapy. I know you're going to get more about the admissions process later, as well as I would recommend that you look at the website www.apta.org. That's our professional association website, and you can find a lot of information there about the profession itself. I've had the opportunity to talk to a lot of students over the past several years in my role in the professional association, including entry-level students that have just started their physical therapy professional career, as well as those that are finishing. So one of the first things I'd like to touch upon, and Dr. Stoffel addressed this as well in her talk, notice we're talking about entering the profession of physical therapy and not becoming a part and doing the job of physical therapy. And there's significant difference there. And if you look at that definition of profession, it's that vocation or occupation that requires that unique body of knowledge that you go to school for, and that requires a lot of mental work as well as manual work. Those of us in the physical therapy field will tell you that we do manual work and we work hard, but at the same time, with clinical decision-making that goes along with it and the education required to be able to make those decisions, it is one of those professions similar to teaching, medicine, law, and theology. So there's a certain set of behaviors to go with that, and that's what we refer to as the others as well, professionalism. So there's that behavior that goes with it, and all those characteristics, and that you gain that status within that profession. And if you just look at some of those terms and ponder on them, I think it'll hit home, and I'll give you a practical example that I've seen hit home not only in my practice, but also you probably can relate to in your everyday life. But it's accountability, altruism, doing that best thing for the needs of the patient, not necessarily for yourself, compassion and caring, excellence, integrity, professional duty, and social responsibility. So in my mind, that's one of the first questions that you need to ask yourself when you're going to enter the profession, whether it be physical therapy or some of the others that you're hearing about today. Can you discern and say, I'm going to make that commitment? And I usually use a practical example. Now, I'm from Pittsburgh, but I know I'm closer to San Francisco, so I'll relate to San Francisco. You're in the clinic, and you have tickets to that Giants playoff game, okay? And you can't wait to go and have dinner with your friends before the playoff game, and that physician calls and says, I have a patient in acute low back pain. He needs your services right away. And you're 20 minutes from going to that dinner with your friends before the playoff game. From a professional standpoint, what's your decision? What's your decision? How do you ponder that and say, what am I going to do? And whose needs do I need to meet at that time? Mine or that patient that really needs my services? So it's not just about the money, but it's building that professional characteristic about yourself as well on how you're going to go ahead and exemplify those. So let's move a little bit more to the specifics in physical therapy so I can talk to you a little bit about where we're at, both as a profession in general, but where you may be working as well. As you'll find when you do some more searching, we're in a variety of different settings. We're in hospitals, we're in home health, skilled nursing facilities, freestanding outpatient centers, as well as in school settings, in the military. As you saw Dr. Stoffel talk about occupational therapists there, we're in the branches of the military as well. We're also in fitness centers. We also have those, and I see later you're going to have USC talk about their sports medicine program, but we're also in professional sports teams. One of the things that we've seen happen, if you remember, there's that labor agreement with the NFL players a few years ago. One of the sidebars of that labor agreement, they came to a unanimous decision on that every NFL team needs to have a physical therapist accessible for their players to go ahead and access treatment from them, as well as the trainers that they have on board. We are also in universities. We need the people that teach physical therapists and physical therapist assistants of the future. And at the same time, we have researchers, and we have great research needs. So you can enter the clinical practice of physical therapy to get started, but those are avenues that we have a great need in. I was just at Educational Leadership Conference the other day in Kansas City before I came here, where our academic programs are together. Right now, we have an estimated need of about 340 faculty members in institutions across the country to teach. And along that way, we also need research. And all of the professions that you will be hearing talk to you over the next several days, we need research to show the value of what we do into the healthcare system with all the changes that are going on. So we want to make sure that we're doing the best evidence-based practice we can for a patient, doing the things that will make them better, and at the same time have research-based foundation to it. So we need people carrying that out as well. So when you look at it, you can enter and get into the practice, education, and research areas, and not just clinical practice treating patients day to day, which gives many, if not most of my physical therapists great satisfaction every day that say they help someone. So if you look in global terms, what we really do, we diagnose and manage movement dysfunctions. We restore, maintain, and promote optimal function and wellness. And we prevent onset of symptoms and progression of impairments, which is loss of motion, loss of strength, as well as functional limitations that may result from disorders, diseases, conditions, and so forth. So that will range across the lifespan. From the child that's afflicted with cerebral palsy due to something at birth, some anoxia at birth that gave them some neurological impairment, to someone like my 90-year-old mother who had a significant medical problem, was in the hospital in the ICU, as well as a step-down unit for 2 weeks, lost a lot of ability, developed some impairments, lost some ability to perform her activities of daily living, and need to go in a skilled nursing facility. So we're across that lifespan like that. Now, if you look at where we've come from a physical therapy profession, we embrace those professional characteristics I had mentioned to you, and we had a vision, and we called it Vision 2020. It was established back in 2000, and we thought we'd go ahead and look at where we're at and say, what do we need to do to meet society's needs? And this is what that vision statement was at the time. By 2020, physical therapy will be provided by physical therapists who are doctors of physical therapy, recognized by consumers and other healthcare professionals as practitioners of choice, to whom consumers have direct access for the diagnosis of, interventions for, and prevention of impairments, functional limitations, and disabilities related to movement, function, and health. So we embarked upon some key elements that we said as a profession we needed to achieve, and some of those were this: autonomous practice. When someone needs physical therapy, that professional, like in the other professions, should decide what those needs are, not have them dictated to them. And I think all the allied health professions and non-physician providers embarked upon that same topic, and we can come back to that in a little bit. Direct access. Right now, there's direct access to consumer services for physical therapy in all 50 states, as well as the District of Columbia, so you can directly access a physical therapist without seeing a physician. Practitioners of choice, therapeutic, not mindless application of exercise. We look at the physical therapist as being the person that when you need an exercise program, it should be specifically designed. We know many of you are in general exercise program to maintain health and wellness, but at the same time, there may be conditions that you need a specific exercise program as well. Evidence-based practice, which I mentioned, research that translates into practice and clearly illustrates our value to the healthcare system. That is an ongoing professional dilemma right now. If you look and talk to a researcher from the time a research article was published in a journal, referee journal, it sometimes takes 17 years for that to come into practice. Way too long, way too long. And we, with our Foundation of Physical Therapy, have actually embarked upon a program to develop clinical researchers that can ask clinical questions and get answers much sooner than that. And then our professional association will help distribute that information so practitioners can better themselves. Doctors of physical therapy, we now have 99% of the programs granting a doctor of physical therapy degree, and those that have not completed granting the master's degree have a plan in place. So if you look at physical therapy, you will be entering a doctor of physical therapy program, 220 of them in the country, as well as some developing. And then professionalism, we discussed that earlier. The essence of our existence essentially is that behavior that exhibit every day to go ahead and become a part of that healthcare team. Now, as you can see, you could say, well, this vision that you had looked very focused and was inward, and it was, and we admitted that. But we really realized with the Affordable Care Act, as well as where we were from a profession standpoint, we need to continue to work in those areas, but also make the commitment to ourselves that we'll go ahead and better the health of society in general. So in 2013, our governance body decided that the profession as well as the association needed the following vision that we're now working on to move through all our documents. Transform the society by optimizing movement to improve the human experience. And we think that better entails what our role is within the healthcare system and how we go ahead and use our knowledge, skills, and abilities for the better health of the general population. Now, as you're all aware, like all the other health professions you're going to be listening to today, everybody's responding to that Affordable Care Act and trying to achieve what is referred to as that triple aim. Better care, lower cost, and a positive patient experience. It's my belief our profession is pretty well positioned to be key players in that, with that change in health care delivery. And as if you can imagine, I'm biased where my perspective is, as well as my years of experience and my position as the National Professional Association, but at the same time, I wanted to alert you that the non-physician provider, in my opinion, is now the buzzword within the healthcare systems across the country, as well as in the administrative buzzword for the administrators of those systems. And I thought what I'd do and give you a practical example of where I see 2 or 3 areas where physical therapy is playing a role along with other healthcare professionals to go ahead and provide care, but at the same time meet the needs of the Affordable Care Act. So first one, I want to give you an interprofessional team model. And I want to jump back to that word I used that was autonomy. And when we started using that term, as some of the other professions found, that has a certain arrogance to it. And people said, well, it sounds like you don't need us. And that really wasn't the case. We realized we needed to really be a member of that healthcare team. So we've kind of looked at that and said that really meant that our area is what we know and what we should make decisions on. But at the same time, we need to be a part of a team. So I'm going to give you an example of interprofessional healthcare team that my physical therapists have been involved in back in my health system, and giving an example of how we're positioned to go ahead and be a part of that team to move healthcare forward and at the same time meet the needs of society. We're the largest trauma center in the state of Pennsylvania at the UPMC system, and we're the second in the country. Okay, tons of admissions every year coming in, multiple traumas of all different types. All these trauma patients are scheduled for an appointment to come back into the clinic. Obviously, the physicians are extremely busy. They have physician's assistants that help them. And we were approached by that team through the physician assistant and said, you know, we don't think we're meeting the needs of the patients when they come through that trauma clinic. We think there are gaps in care. They're not getting what they need, so how do we go ahead and approach this? So here's what happened. We developed an intercollaborative team between physical therapy, occupational therapy, speech therapy. There's a nurse clinic coordinator. There's a physician assistant at that clinic, as well as an audiologist, a nutritionist, and a rehab counselor. That team sat down and said, what are the screening tools for the different disciplines? What do we need to look at when a patient comes in? They get that list of patients on the schedule with their past history and their diagnosis. They decide who screens that person first. If that person would indicate they have not been able to start weight bearing on a leg that hasn't healed yet, and at the same time they have weakness and they have loss of motion, then the physical therapist should probably go in first. If they truly indicate by what they've seen on the diagnosis, their activities, daily living limitations, functional limitations, those occupation things that Dr. Stoffel had alluded to, the OT would do the screen first. All those disciplines go ahead and then collaborate and give a screening report back to the physician's assistant who reports that on to the physician. We've got high patient positive satisfaction from that. They say that their needs are being met. An interesting sidebar, how all of us in the healthcare team realize sometimes that as you have probably gone into some clinics and say they're missing the boat, so to speak. One of the things that was most interesting, that team has decided to go ahead and have the audiologist see the person first. So all the disciplines could go back to that autonomy that we talked about and say, why not me? But I'll give you a guess as to why the audiologist went in first. Over 65% of the patients came in with a hearing loss. They weren't confused. They didn't have a head injury. They didn't really understand. They couldn't hear. So essentially, the audiologist goes in first and essentially gives them a temporary hearing device if needed. And then everybody's experience, from the PT, the OT, as well as the speech-language pathologist and physician's assistant, is a much better experience, and the patient is much more appreciative of the care they've got. So that's one example, physical therapists functioning at the highest level of their license, along with the other professionals, providing some collaborative care and meeting the needs of the patient. And again, we've gotten some great feedback on it. My second example is one of the largest costs in the healthcare system is the management of low back pain. If you talk to any health plan across the country, they'll tell you their musculoskeletal costs are escalating off the charts. And there are various numbers out there, but I can tell you between loss of wages, pain, suffering, care, and all that is probably in the billions of dollars every year. We're seeing health systems like our own develop evidence-based practice guidelines that says how do we best manage a person, for example, with low back pain, and say what the evidence is and who's the practitioner they should possibly be guided to first, rather entering into expensive testing and seeing specialists and all that unnecessarily. All those people have been sitting at the table, and one of the things that we've seen is that with the proper screening for red flags of disease, as well as needs that the physician may indicate through their screening process, they can often see a physical therapist first, and we can stave off some of these high-cost procedures that don't necessarily need to be done. So the imaging and the testing that maybe is an added downstream cost to the health system is not necessarily there. So from these examples, I hope you can see that physical therapy and that profession is an integral part of the healthcare team. And in a variety of different settings, we're looking for the professional opinion as well as expertise of the physical therapist to provide their input to that team, so those patients go ahead and meet the best care that they can head on rather than some unnecessary care, and they get the appropriate care. So a lot of times we use the phrase, right care at the right time by the right person. So I would encourage you again to go to www.apta.org and find out more about the programs, as well as some various settings. There are some great examples there on our website with videos of people working in different settings, and pursue it further. I'll be available for some questions now. We have some time as well as afterwards, but I thank you for giving me the opportunity to speak with you today.